The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
Tonight, how drugs like Ozempic are changing the conversation around obesity. Then, Nam Kiwanuka and guests on why menopause is having a moment. That's ahead on The Agenda. Ozempic and other GLP-1 drugs have exploded in popularity largely due to their effectiveness in treating type 2 diabetes and perhaps more significantly, their weight loss effects. But what do we know about these drugs and how they work? Joining us to discuss the knowns and unknowns, we welcome Dr. Daniel J. Drucker, Senior Investigator at Sinai Health's Lundfeld Tannenbaum Research Institute and Professor at the University of Toronto's Department of Medicine, on the line from University of Toronto. Dr. Sanjeev Sokalingam, Senior Vice President of Education and Chief Medical Officer at the Centre for Addictions and Mental Health. He's also Professor of Psychiatry at the University of Toronto and Scientific Director at Obesity Canada. And Nishta Saxena, Registered Dietitian and founder of Vibrant Nutrition. Thank you so much for joining us in studio, and Dr. Drucker for joining us on the line. Dr. Drucker, I'm going to start with you. Your research led to the development of these drugs. How did that happen?
Well, we were trying to figure out what these sequences in the DNA of the glucagon gene were in the 1980s, and we saw these glucagon-like peptide sequences. We had no idea what they did, where they were made, if they were active. And my experiments just set about to say, what did they do? And we finally hit some exciting data when we saw these peptides, predominantly GLP-1, stimulates insulin secretion and allows islet cells to make more insulin. And those were really the first biological activities described for GLP-1 in the mid-1980s.
All right. A lot of people are hearing the word Ozempic a lot, but they're not necessarily hearing GLP-1 like you mentioned or semaglutide. Can you walk us through a little bit in layman terms? Break down the science for us exactly how they work. Yeah.
So our body makes dozens of hormones. We're all familiar with cortisol or thyroid hormone or growth hormone. And the body also makes a lot of hormones in our gastrointestinal tract. And glucagon-like peptide 1 is one of the hormones that our body makes. And it's very sensitive to food intake. Its levels rise. It helps us assimilate the energy. It tells the pancreas to make more insulin and helps us control our blood glucose, and also sends a signal to the brain to tell us when we're full.
Dr. Sokalingam, talk to me a little bit about what you've seen with Ozempic, the research that's sort of been done. Pick up sort of where Dr. Drucker is in terms of its ability to work and work on the GI.
Yeah, well, I think we've seen a lot happen. We have a lot of literature from diabetes where it initially was being used. And over time, we've seen how research has shown and indications for its use in obesity. And really where it works is in terms of giving that sense of satiety or fullness that we see, and that's the brain-gut interaction in some of the parts of our brain, like our hypothalamus and regulation of hunger and those drives, but also on aspects of reward and some of the motivations for eating and drive for eating. That wanting, so to speak, that's sometimes signaling. So there are receptors in the brain that also have GLP-1 that are also impacted. And this is where we see things where patients tell us they're feeling more full on these medications. They may also talk about something anecdotally, not a scientific term, but reductions in like food noise or the importance
of...
Food
noise, what do we mean by that?
Where patients tell me that they have less time or less real estate that they spend in their brain on food, and that they are not thinking about food as much. Some of those cravings come down, and they're able to feel like a release of some of that energy, time, and space in terms of their food preoccupations.
All right, Nishta, Ozempic was originally made and approved, of course, as we mentioned, type 2 diabetes, but not everyone is using it that way. How do people get these drugs to use for weight loss?
I would say primarily, I have quite a gamut, a range of patients now that are using these drugs, and they're primarily going to the family physician. And because there's so much awareness about them, they're going there with, the desire and the asking for these drugs in particular, particularly people that have struggled with obesity, for their entire lives. They're seeing it as hopefully this kind of beacon of light and hope in the path to actually, not living with obesity anymore. So I would say the primary place is family physician, but of course, clients that are working with a psychiatrist will also, as Dr. Sangalam just mentioned, maybe also asking for these drugs, or they may be using these drugs and being prescribed by mental health care providers as well.
Now, with Ozempic, I'm sure a lot of people are hearing it because they're seeing celebrities using it, and they're seeing a lot of people with success there. I'm curious, with people with the gamut of clients, are they coming up to you and being like, I've been hearing about this? How are they approaching sort of that conversation with you, knowing that they have to go to a doctor, but what's that initial conversations with you?
Yeah, absolutely. They are kind of wanting, a lot of people are wanting to work sort of from the outside in, right? We all know that lifestyle changes, and I do want to preface this by saying, obesity is not a drug, is not a disease of willpower, right? It's very complex, comorbid conditions that come together for people to be struggling with this. So when they come to me, they know that things that they need to do, things they want to engage in with lifestyle, but they feel the sense of, if I use this drug, it'll give me a kickstart. Maybe it will start that process, and then the momentum of that and feeling different in my body, my thoughts being different, will help me then engage with some of these lifestyle changes. And they absolutely are coming to me with the goal of a lot of weight loss. So they're not really looking at it as a small thing. These are often people who want to lose 30, 50 pounds.
Right.
And so they're really approaching it with that attitude of, I want to lose this much weight.
Very good. Dr. Drucker, if people use the drugs off-label, obviously they won't be covered by most public or sometimes private insurance. I'm curious, how much are people paying for this out of pocket?
So the drugs are very expensive, and there is more and more competition in the United States where the drugs are much higher priced. We have seen prices come down now from over $1,000 a month to $500 a month. More recently, Eli Lilly and Novo Nordisk are launching cheaper versions without the pens and vials, $400 a month. In Canada, probably anywhere from around $300, $400 a month for the newer versions, maybe $250 a month for the older versions, but they're still very expensive medicines.
I'm curious about patents. Is this something, when we're talking about generics, are those available, or is there some time before we get there?
So we are going to see generic liraglutide, which is one of the earlier versions approved for weight loss in Canada. It was launched in 2014, and there are no generic versions on the way. Semaglutide will probably be generic in 2 to 3 years. The companies always engage in legal strategies to try and prolong this. And of course, then we've seen people making compounded versions of these medicines, which is another entire subject of controversy that bypasses the companies, and will have more competition in a couple of years. But for now, accessibility and cost are still major issues.
All right. I want to pull up a study. A 2024 study from Dalhousie University estimated that around 900,000 to 1.4 million Canadians were taking a GLP-1 drug. Now, 57.1% said they were taking for type 2 diabetes, 27.2% said they were taking for weight loss, 11.6% said that they were taking for both weight loss and type 2 diabetes, and then 4.1% said other. Now, I'm curious about this 4.1%. I don't know, I'm sure there's a few things there, but Dr. Sangalam, do we know what else people could be using GLP-1 drugs for?
Well, I think you alluded to it earlier, that I think there are maybe some people who are taking it maybe for weight loss, but maybe an off-label for other things and cravings in other realms. There has been a lot of debate and discussion and emerging research on the use of GLP-1s for cravings and curbing kind of addictions, for example. I don't know if that 4.1% is that group. Right. It's still pretty early for that. But I do wonder if, for example, some people may be using it to curb other cravings. There are some animal studies and some early human studies that looked at nicotine use and alcohol use and looking at associations and reductions. But larger trials are currently underway. I would say the other is other people may be using it for these fluctuations in weight that might not be weight loss, but weight cosmetic weight modification. People cycling or tinkering with their with little small doses to help with modulation of weight maintenance.
Okay, very interesting. Yeah. All right, Nishtep, that estimate that I gave, 900,000 to 1.4 million, sounds like a large number, but I should have mentioned that study is from 2024.
Okay.
A lot of time can change. I'm curious, do we think that number could be a lot higher? Do we have a rough idea of how many people are using something like Ozempic?
Well, I can definitely say in the past year and a half in my practice, in my clinic, the use has skyrocketed. So even if I looked at it as a percentage of patients that I would see and clients that I would serve, it's definitely quite a large percent of people for the variety of reasons that you're describing. It really isn't, the majority of people that I am seeing on this drug are not actually taking it for the management of type 2 diabetes. They may already be taking medications for the management of that, and they've started this drug to kind of start the process of trying to manage their weight. So I do actually think the number is probably higher.
I am curious, it sounds like an obvious question, the application of something like Ozempic or Wegovy, how does it apply?
It is an injectable drug, and it is something that has to be dosed properly. So it is something that you would start off with a starting dose, and then you work up to a maximum dose with the physician, and that does take time. And then you also have to attribute and take time for understanding how people will react. The one thing I want to say is of all of the different clients and patients that are using this drug, it's very individualized reactions and very individualized results as well. So we want to make sure that patients are aware of that.
All right, I want to pick up on that with Dr. Drucker. These individualized sort of reactions. I also want to talk about side effects as well. What are some of the side effects people can experience if they are taking this medication?
So the most common side effects are nausea, diarrhea, constipation, and vomiting. Those occur in about half the people who take them. They tend to be transient, and we see them when people start the drug or where they increase the dose. About 90-95% of people after a few months will not have any of those side effects. Then, more rarely gallbladder disease, sometimes dehydration, if you really are unable to eat and drink. So we have to counsel people about this. Then there's some more controversial things. People talk about rare types of eye disease or rare types of kidney disease or pancreatitis, etc. Those actually have not being definitively proven, but they are something that we discuss. And the important thing which we've heard about is we can start a low dose and go slowly. So the acronym sort of start low, go slow. We don't have to repeat the rapidity of which we increase the dose of these medicines that are done in the clinical trials. We should not increase the dose of these medicines in people who have any side effects. We should wait till they become used to the medicines and go much more slowly. It often takes 10, 15, 20 years to gain a lot of weight. We don't have to reverse that in 6 or 9 months. So we have to have an individualized approach to management.
All right, Dr. Soccolingo, I'm curious, when I'm thinking of a type 2 diabetes medication, I'm thinking of metformin or something like that, something that, I'm not throwing my mom under the bus when she has to take it, she has to take it every day. I am curious with something like Ozempic, do people need to take that drug, do they need to stay on it forever to be able to see it, or if they get off of it, will they see a reverse?
Well, I think it comes back to Nishta's earlier comment that obesity is a chronic medical condition, right? So with diabetes, right? It is a condition that we manage for the rest of our life through various interventions. It doesn't always have to be medications. It's often multi-component, and that applies to obesity as well. And even though we've accepted obesity as a chronic disease in the medical field for some time, in society, it's still an uphill struggle with respect to that. So how does this relate to patients? I do counsel patients on this. It's the first question they ask is, how long do I have to stay on this? And I do say it is like any other chronic disease, like diabetes. If you had high blood pressure, for example, you're going to stay on the medications to manage that, and you're going to do a whole bunch of other things as well in terms of behavioral, lifestyle modification, and so on. And then we will reassess over time. But for many patients, they do have to stay on these medications for a longer period of time. And I'm committed to working with them on that. And that's, I think, the main thing is that we reassess together. It really is something we have to educate, because many people see that initial benefit and want to go off the medication because they're better, just like antibiotics. So you cure your infection, do you want to go off it? So we do have to counsel patients with respect to that.
All right. Nisha, are GLP-1 drugs a sustainable form of weight loss?
Well, that's the question of the day. And the way that I would look at it is it's like so many other interventions we've had in the past 20 or 30 years to try to attack obesity. It is a tool in the toolbox. So it is something that can be absolutely utilized to help with sustainable habits. But I think in and of itself, it's not a quick fix or the answer to everything, because as we've heard today, there are so many factors that influence obesity and the development of it, and it's a chronic disease. So it is something that people will manage over time or over many years, or have been, and therefore I do think it is an important tool. I think it's a useful tool. The sustainability really does come into play when you look at what are the other pieces that we can help patients and clients get into place, because I do think there's multiple factors that need to be activated for this drug to even have its most potent and beneficial effect. So that's the way I kind of look at it, similar to many other interventions over the years, that as soon as they are kind of on the market, people are very excited about them, and they kind of think, oh, this is the quick ticket.
Right.
We really don't want to do that with this time. There's amazing benefits to these drugs, but I do think we want to think of it as one tool in a multi-tool box.
All right, very well. Dr. Drucker, I want to talk a little bit about some research from the University of Alberta. Last year raised some red flags about the potential for semaglutide to shrink the heart and other muscles. Is this something people should be worried about, or is this early research? Where are we at?
I think you're referring to a study that was done in animals, and let's remind ourselves what we know after 20 years of using these medicines in people with type 2 diabetes, and about 4 or 5 years with the more modern drugs in obesity, and 10 years with liraglutide obesity. So we have fantastic studies in people with a history of heart disease that these medicines reduce heart attacks, strokes, death from cardiovascular causes, and your rate of dying in general, and as well as reduce the symptoms and severity of types of heart failure. So although the animal studies are intriguing and we can always learn more in humans, I think these drugs are among the safest medicines for your heart that we've ever seen in people with type 2 diabetes and in people with obesity.
I want to pick up on that when you're talking about heart disease, Dr. Drucker. Health Canada now says that the drug Wegovy can help treat heart disease. Break it down for us in layman terms. How does that work?
So we have actions of GLP-1 on our blood vessels, probably on the development of plaques that we call atherosclerosis. We know these medicines affect blood flow. They actually control the amount of blood fats that our gut releases after we eat. They reduce blood pressure, and they reduce inflammation. So all of these beneficial effects probably work together to reduce the development of heart disease in susceptible people.
All right, Dr. Sucklingham, there's also research suggesting that GLP-1s could treat lots of other conditions like Alzheimer's, arthritis. Is it too early to say this is a miracle drug? It seems like we are treating a gamut of chronic issues here with this drug. There's some excitement there.
Well, I would say it's too early to call it a miracle drug. I'll just say that. I think it's very nice to have a great drug and treatment in our toolbox. I think what you're alluding to is, in addition to what Dr. Drucker just spoke about in terms of the cardiovascular benefit, we are seeing that these GLP-1 receptor agonists are having effects beyond weight loss, right? Reductions in sleep apnea for treatment, fatty liver disease, for example. And really, if you look at it, if you think about obesity as a chronic disease, obesity is associated with many chronic medical conditions. It's bad for our heart, blood sugars, blood pressure. It's bad for our brains, all right? And so we're seeing that if maybe we treat obesity upstream and early, you may be able to prevent potential medical illnesses and diseases as well. And so this is where we're trying to figure out where this might work, in addition to this specific drug having some beneficial effects on the body as well.
I want to pick up on a thought that you had mentioned earlier about sort of the excitement, sort of with dealing with cravings when we talk about addiction. You, of course, work at the Center of Addiction and Mental Health in Toronto. How exciting is it to be sort of with the possibilities of these findings?
Well, I think, again, if we look at, I'll take alcohol use disorder, because that's one area where we're seeing a bit of traction and research underway for GLP-1s. We don't have a lot of great treatments. We have a lot of psychological treatments that are effective. We have a few medications that are useful, and similar to other chronic diseases, addictions wax and wane. And if we could have another treatment that could help, be quite beneficial. And as I alluded to, GLP-1s affect that reward pathway that we see for kind of food as a reward, and especially highly caloric, dense type of food, similar to like alcohol and other substances where we're hitting those reward pathways and that dopamine kind of signaling as well. And so you can see that theoretically there are some parallels. And this, I think the research and trials underway are going to really tell us how effective is this treatment and for how long. And can this be part of the toolbox for addictions treatment?
All right, Nisha, do you think these drugs are changing the way we view obesity in general?
Well, it's an interesting question. I think that as time goes on and sort of you alluded to Hollywood, and watching a lot of celebrities who probably don't admit that they're using these drugs to maintain or even lose weight, I do think there's an interesting question at play there. If we are still in a state of looking at somebody's body size, the bias that comes, the weight bias, judging people because of the shape of their body versus what's actually happening inside of their body, etc. There could be a risk of, if everybody is meant to be a certain size and going back to that kind of sizeism, etc. I think ultimately this type of drug and the use of this drug really has to be a conversation with a doctor and a patient about what their goals are. We really want to understand and look past just weight and numbers on the scale as a metric, because as we've talked about, the impact on the way that you're thinking about food, how you feel about food, your mental wellness, your mental health, your energy, your ability to perform in your life the way that you want to. All of these things are part and parcel of becoming healthier and controlling or managing obesity. And so if we can also help people understand it isn't just about a number on a scale, and a number on a scale doesn't necessarily mean that you are healthier. Of course, it can start that pathway, but we want to look at all of those pieces together because, we don't want to end up with a society that's looking at on your resume at the number of your weight instead of who you are as a person. All
right, Dr. Drucker, I'm curious, because of the early research that you did, I'm curious, looking back, did you ever think that the success that the research would have in the way that it's being applied? I know there's a lot of early research that's still being done on some other stuff, but are you surprised at how far? Did you ever think that that research would be applied to what it's being applied to now?
Yeah, and I want to come back to one of the previous comments. So I think when we started this in the 80s, we were focused on the diabetes piece, stimulation of insulin secretion, and there was a vision that this might be useful for diabetes. But the weight loss story started in 1996, and none of us, I think, would admit that we could have imagined this range of actions that we'd be contemplating. I think a really important message for our society is that for many years, we have sometimes looked at people living with obesity and tended to blame them and ascribe a lack of willpower and say, well, you're not really trying. If you wanted to lose weight, you could really lose weight. And all of a sudden now, with the aid of GLP-1 medicines, these people can lose spectacular amounts of weight. And I think it allows our friends and family members who are living and struggling with the challenge of obesity to turn around to the rest of us and say, you see, I actually can lose weight. I did want to lose weight. I just needed help, just like I might need help for cancer or liver disease or inflammatory bowel disease. And that's, I think, tremendously affirming for people living with obesity, sometimes living with some stigma from colleagues, et cetera. And I think that's a wonderful aspect of these medicines.
Dr. Sakalikam, I want you to pick up on that because I saw you nodding your head there. Just that idea, I think even just the way that you phrased it, treating something like cancer or something, I think of it like that. How does something like Ozempic change the game in that way?
Well, I think, as Dr. Drucker talked about, a lot of people living with obesity face tremendous stigma. And I'm embarrassed to say, as a healthcare provider, about 50 to 70% of kind of weight bias and stigma that people have experienced has come from healthcare providers. And as a result of that, the advent of GLP-1s and their treatment, as Dr. Drucker alluded to, has opened the dialogue about obesity as a chronic disease, having treatments available, that perhaps there is a brain-gut physiological interaction, and it's not about me being lazy or lacking will or not being able to make these diet changes. You start to open this dialogue with people in society. So this has been really paramount to trying to address decades and decades of stigma that people have experienced. And now it also opens the door to think about obesity beyond weight and BMI, right, and body mass index. Because if we think about it as health, we open this whole dialogue about people having biological, genetic, other variables, like every other chronic medical condition. There are treatments now available. There's hope. And now people are having experiences where their physicians or other healthcare providers are actually now saying, wait, I have a tool now, I can help you, and I understand this is a medical condition, and it's not your fault. And so now we can have these corrective experiences in healthcare.
I am curious, are people being judged for using a drug like Ozempic?
Yeah.
Say taking the easy way out or something like that.
Yeah, so I mean, I work in a center that does medical and surgical treatment for obesity. It's the same thing when we had people going through surgical treatments for obesity. Same thing with GLP-1s that I see in my practice, where certain family members are open to a dialogue and see and have an understanding, but others are, well, this is the same stigma that they had before, that you should just be eating better and exercising more, which we know is not the treatment for obesity. All these treatments in Toolbox help us to eat better and to exercise more, which we all should do in society. But what it ends up happening is really that there's a faction of people who actually still blame people and say you're taking the easy way out. You should be able to do this on your own. We need to correct those experiences and that dialogue.
All right, Nisha, you get the last word here. If more and more people take drugs for weight loss in the future, look through that magical ball into the future, can you imagine a world without obesity?
That's a really interesting question. I would say no. I think because it is such a complex disease, there are multiple reasons, and we've talked about those here today, that will impact whether or not somebody is obese. The other thing I will say is the individualized response that happens with these GLP-1 drugs is very individualized. So I have had clients who have only lost 10 pounds. Yes, there are clients who may lose more than that, but it doesn't necessarily work the same way for each person individually. So a world without obesity, I'm not sure if we will necessarily ever see that. I also think it's very important to note that, the shape and size of people's bodies, where they carry weight, muscle, and fat, is very genetic. So even if we change, the body weight on their body, we also have to look at, shape, size, and then we get into, skin color and all of those different things that make people individuals. I don't want a world where everybody looks the same. Right. We want to make sure that we're respecting the biological and genetic differences between us, and not just hoping that everybody is of equal size.
All right, well, we're going to leave it there. Nishtha, Dr. Sokolingam, Dr. Drucker, thank you so much for joining us. Really appreciate it. Great insights. Thank you.
Thank you.
Yeah.
Is menopause having a moment? From the advocacy work of activists to high-profile women like Halle Berry discussing it openly, what may have once felt like a solitary experience for millions of women is being brought into the mainstream. Joining us to discuss why, we welcome, on the line from Calgary, Alberta, Christina Frangu, freelance writer and a journalism professor at the Southern Alberta Institute of Technology and the Dalla Lalla School of Public Health at the University of Toronto. And with us in studio, Dr. Wendy Wolfman, director of the Menopause Clinic and the Premature Ovarian Failure Clinic at Mount Sinai Hospital and professor in the Department of Obstetrics and Gynecology at the University of Toronto. And Trish Barbato, co-founder and director of the Menopause Foundation of Canada. Welcome to you all.
Thank you, Nam.
Can I say how excited I am to speak about this, because talking about menopause has been very kind of like, you don't talk about that. You don't talk about that, especially on television. And now we're on TV talking about this. So thank you so much. Dr. Wolfman, I wanted to start with you to just help us understand the terms. Can you explain it to us, what is perimenopause, menopause, postmenopause? How do we mark these?
Right. So actually menopause is a point in time, and it refers to the last menstrual period. And you can only define it retrospectively after you haven't had a period for a year. And the reason that it happens is that women are born with a certain number of eggs.
Okay.
And over their lifetime, these eggs decline. And around the age of 35, they start accelerating a loss. And then over a period of time, because of this acceleration of loss, there are changes not only in a woman's fertility, but also the cells around the egg that produce hormone, typically estrogen, and then when women ovulate, progesterone. And because this wonderful computer that occurs every month in reproductive age women starts to fail, then we start having changes in our cycles. And that's one of the first hallmarks of the perimenopause, typically in women's 40s, late 40s. And then because of these fluctuations in hormones, women start experiencing symptoms. Sometimes they can experience symptoms of very high levels of estrogen, such as sore breasts, even nausea, heavier periods, particularly if they also have some underlying pathology on their uterus, and it responds in a different way. And then actually in the 6 months before the last menstrual period, women can start experiencing symptoms of decreased estrogen, and we can talk about that afterwards.
I was surprised to learn that perimenopause can actually start as early as 35. When you're explaining about what's going on with the hormones, can you explain to us what's actually happening to our body? Because I think the idea, whenever we hear about menopause, we hear about the hot flashes.
Right.
But what else is happening to our body?
Well, because of these fluctuations of hormones, women can experience these symptoms that I mentioned, which can be sore breasts. Sometimes migraine headaches get worse. If they have fibroids, those fibroids can grow in those years before. They can have more mood change. And in the year before the last menstrual period, we also know that now, and this we didn't know before, that there are acceleration, a lot of some of the problems that might go on after menopause, changes in blood pressure, changes in body fat. So women put more fat on their visceral area or their tummy area. Also, they can have acceleration of bone loss, which actually within 3 years of the menopausal period, you can lose 10% of your bone. And a lot of these things are silent. So
these are serious things that happen to our physical
Right.
body, but yet menopause is something that we don't really talk about. And now it seems like we're living through a time when a lot of celebrities are talking about. Trish, what do you think about, what do you make of that moment right now that's happening right now?
Yeah, well, I'm really excited about it because more has happened in the last 12 months on menopause than the last 1,200 years, probably. So I'm really excited that we are talking about menopause. And it's so critical because, as Dr. Wolfman said, people underestimate, women underestimate, but society underestimates the length of time that this is happening for. Perimenopause can happen 2 to 10 years before menopause. Postmenopause goes on until you die. So we're in a long, long period, decades, where women can be suffering from symptoms that are having a huge impact on her health, on her life, on her ability to work, on her ability to care for elders, children, etc. So it's a huge issue that as a society, as a workplace, as a healthcare system, we must address.
And Christina, we know that 100% of women will have some kind of symptoms of perimenopause, menopause. We'll go through this, yet we're only talking about it really now. Can you talk to us a little bit about how it impacts people's daily lives?
Oh, I mean, it's massive. I wrote a story for the Toronto Star about this a couple of months ago, and one of the people I spoke with was a gynecologist here in Calgary. She has a 2-year wait list for people who want to see her about their menopause symptoms, but she was struggling with brain fog and memory loss and forgetting the word for things that she used in the operating room. And she didn't even recognize those symptoms in herself. And so she went and she saw her doctor to say, like, am I going to be able to continue working? And so I think it's that pervasive. It's forgetting things at work. It's having the hot flashes when you're sitting there with your friends. It's absolutely not being able to sleep at night. It's all of these things.
And it's weird because within my friend circle anyway, even on social media, a lot of us seem to get up at the same time in the middle of the night, like 3 o'clock in the morning. You're just up. And when you think about your career, a lot of us during this time, we're doing, we're in senior positions of leadership. And it's frightening to see, like when you're dealing with brain fog, how that could impact your career. Dr. Wolfman, can you help us understand what's happening to our brain during this stage of life?
Can I digress a bit?
Okay,
because we got as far as the menopause, and I want to be clear that the symptoms occur due to lack of estrogen are different. And the really important symptoms are hot flashes, which is a sensation of heat or warmth, starting in the chest and moving upward to the head and neck. Night sweats, which interrupt sleep, and therefore may impact cognition. Also, you talk about brain fog, which is not a well-defined term. And then also, we know about 40% of women have sleep issues, mood changes, especially in women who are vulnerable to changes in mood around hormonal change, like puberty, postpartum, and then around menopause. But there can also be new changes in mood, such as irritability, anger. Even people can have panic attacks around menopause. And then we also know that there are symptoms that we don't talk about hardly at all, and they're called genitourinary syndrome of menopause. And that refers to the lack of estrogen on the vulva, the vagina, and the pelvic floor muscles. And that causes dryness, irritability, difficulty with intercourse, and decreased sexual desire is a validated menopausal symptom. So all these things occur when estrogen starts to go down once those eggs I talked about become depleted. And as Trish said, the symptoms we used to think happened for about maybe a couple of years, but there's something called the Study of Women Across the Nation that validated that the average time they last is 7 to 10 years. 40% of women have symptoms into their 60s, and 10 to 15% of women have these symptoms into their 70s.
That's a long time.
It's a long time.
Christina, you mentioned that there was a 2-year waiting period for just to get the care that you need. Can you help us understand how menopause was treated in the past?
Oh, I mean, it's such a fascinating story, and Wendy can help me out here a little bit in telling it. But Canada has a long history here. In the beginning, it was sort of ignored, and then about a century ago, an endocrinologist in Montreal discovered that if you gave women estrogen, they didn't seem to have so many problems. But that was a really expensive way to deal with it. They were getting the estrogen from estrogen made by the placenta during pregnancy. And when they realized that was too expensive, they moved to using pregnant mare's urine. And that led to a medication called Premarin, which was one of the most highly prescribed drugs in North America for a long, long time. And it was, the marketing around it is so interesting. And I mean, get on the internet and do like searches for old magazine ads for this. They're all marketed to men. They say, like, keep her this way. Premarin, it's for husbands too. Like, really, women and their needs were sort of an afterthought in the way this was marketed. And then it was given to women in their, 40s, 50s, 60s, I think even 70s. Wendy can jump in here with the exact age groups that this was being given to. And then in 2002, everything changed with the results from the Women's Health Initiative study when that came out. And suddenly it set off this big scare.
And that had to do with cancer, right? Did you want to talk about it?
Right. So this is actually an excellent study, although we talk about it now maybe in not such positive terms. But it is a prospective randomized controlled trial, which means that you divide up the women and compared what they're taking to placebo or a sugar pill, and then you follow them over a number of years. And over those number of years, they had assessments going forward every year or so, looking at all the risk factors. And actually, it wasn't a study to see whether taking hormone therapy prevented symptoms. It was a study to see whether taking hormone therapy prevented the diseases of aging. And the drugs that were chosen were, as Christina said, Premarin, which was the most commonly prescribed hormone therapy at that time. Premarin, pregnant mare's urine. So it comes from pregnant horses because they make lots of estrogen when they're pregnant. So it was easy to synthesize. And the progestin was called medroxyprogesterone acetate, which is a synthetic type of progestin and is very good at preventing uterine cancer. So they had an arm for Premarin alone for the women who had a hysterectomy, and for women who had a uterus, they got both the estrogen and the progestin. After 5.2 years, a previously described hazard ratio was exceeded for the women on both the estrogen and progestin, and so the study was stopped. And it was mainly exceeded for cardiovascular disease, but when they broke the code, they also found there was more breast cancer. In the women who took the estrogen alone, that study kept going on for 6.8 years, and they stopped it because there was a teeny tiny bit more stroke. But actually now we have a 20-year reevaluation of the WHI. In the women that took the estrogen alone, there was 20% less breast cancer, not more. In the women that took the estrogen and the progestin, there was a little more breast cancer. But when you looked at the ages 50 to 59 in that study, all the risk factors were very, very small, and probably benefits outweighed the risks.
So in essence, hormone replacement therapy does not necessarily cause cancer?
Not in that study with Premarin alone.
I think because, Trish, I want to bring you back into this because when it comes to trying to figure out what is happening to you, we have a family doctor shortage in this country. If you don't have a family doctor, you end up relying on the internet. And then this study has been brought up a lot as to maybe why women shouldn't have access to HRT. What do you think is going on around the messaging around what's available to women during this phase of life when there seems to be a lack of information?
Yeah, well, I think exactly what you said. What we have is we have the stigma and the taboo and the silence around menopause. We have the inability for women to understand what is happening to their bodies. We have lack of knowledge, and we do not have access to appropriate care and treatment in this country, all leading to an avalanche of suffering for women. And that must end. What we found in our data is that women trust their primary care physician. They trust that person as the one they want to get advice from and to counsel them on what should happen around their symptoms. What we found is that less than 40% found that help to be effective. They felt untreated, undertreated, and so there is a lack of knowledge, not their fault. They have no education, hardly any education on menopause. So we're talking about millions and millions of women trying to get help, not able to get it.
You used the word suffering, and I think when people hear about menopause, it's just kind of shrunken into this, it's just a process of aging. Is there a lack of research and funding in this area and understanding of what's really happening?
There is a huge lack of funding and resourcing and research in this area, and I'm sure Dr. Wolfman will attest to this. There are so many areas that we need a deeper dive in. You talked about some of the symptoms, but there's so many symptoms. Another thing we found in our data, women did know, 80% knew, yes, night sweats and hot flashes, but when you got into other symptoms, they had no idea they were associated with perimenopause or menopause. Things like frozen shoulder, itchy skin, joint aches, changes in taste, like all kinds of different symptoms that women were experiencing. They could not attribute that to what was happening in their bodies. They didn't realize it was associated with this time of life.
Dr. Wolfman, I'm going to come back to you, but I want to bring Christina back in. Christina, you cover this issue of women's health. In your view, is there a lack of funding and research for women's health in general?
Oh, Absolutely. And we're about to see big changes come from the United States in the amount of support there is for women's health. And so it's not about to get any better. I don't have the figures off the top of my head to tell you how much or how much little research there is. But to say, it took years before this was even really discussed. And we don't have specialists available to help women with these issues. And Trish talked a little bit about women have these symptoms that are ignored, that are symptoms of perimenopause. I also wonder about the other effect, and that's women know these things can be symptoms of menopause or perimenopause, but then they ignore them and they don't get them checked out, and maybe they're actually something else. And so we just need better supports for women in terms of research and availability of healthcare practitioners.
It seems now that if you have a family doctor, you're one of the lucky few. Are family doctors equipped to manage menopause?
One of the women I spoke with in my story, a gynecologist, said no, they're really not. And they're also like the WHO, the WHI, that when those results came out, there was so much fear about putting women on hormone therapy. And so there was a lot of directing women to gynecologists for specialized care. But here in Alberta, I mean, we have this massive wait list for gynecologists. I imagine it's the same across the country. And so here, gynecologists are saying we want family doctors to take up more of this. Family doctors don't really have a lot of training in this. And so women don't quite know where to turn.
And Dr. Wolfman, if you do have a family doctor, and maybe that family doctor is not giving you the help that you need, and there's not enough treatment options, where do they turn?
So I think it's a huge problem, because even in the undergraduate curriculum, even in the gynecology curriculum, there's so little time spent on menopause. As a gynecologist, you spend hours and hours in the operating room. You spend hours and hours delivering babies, and you're trained in what we call MFM, maternal fetal medicine. And yet we hardly have any lectures or time on menopause. And every woman, if she lives long enough, will go through menopause. Not every woman now gets pregnant. Women live longer. They spend 30 to 40 to 50% of their lives after menopause. So we've been really trying to push more in the curriculum. There was actually a study in the U.S. looking at all the residency programs across the U.S. They surveyed about 300, and only something like 30% had instruction in menopause. So this goes to, I think, what Christina said about there was a big backlash after the WHI, and people were afraid to prescribe hormone therapy, but it left women not knowing where to go. And it was also physicians who were afraid, and faculties who perceived this as trivial, related to ageism, a women's problem, not real medicine. I think the other thing that happened in the last few years is we now know the physiology of a hot flash within the brain. And we know that a hot flash is an inappropriate stimulation of your thermostat, we being mammals having to keep our temperature within a narrow range. And when that's transgressed, you start sweating to lower your temperature. So I think this discovery has changed also the attitude of physicians to respect the symptoms, and also the discovery that women who have very severe symptoms have a higher risk of cardiovascular disease as they age. So I think this is changing the discussion for physicians, but we have a lot of work to do in our undergraduate faculties and our postgraduate faculties. And we at the Menopause Clinic at Mount Sinai, we try and run courses. There are organizations such as the Canadian Menopause Society, the International Menopause Society. Endocrinologists also are very interested in this field. So we're all trying to get on board to improve education and access, because we know it's so lacking. We talked about lack of research. The Biden administration actually had an initiative to improve funding for women's research. I don't know what will go with that now, but they had started that. And I think we should do that in Canada too.
It's an opportunity, perhaps.
Yes, absolutely.
I wanted to get into some data from Trish's organization because some people might think that this is not something that impacts me, but women, we make up half of the economy. This is from the Menopause Foundation of Canada. Women over 40 are a quarter of the workforce. From age 45 to 59, 14% of women leave work compared to just 10% of men. Unmanaged symptoms of menopause cost $3.5 billion per year. $3.5 billion per year, including $237 million in lost productivity. Dr. Wolfman, what should we take away from these numbers?
This speaks to the import of treating symptoms. Like, this has been really the passion of my life, to allow women to utilize all their skills that they've acquired over their lifetime during menopause and postmenopausally. And in this way, we improve not only the health of ourselves, our partners, our families, but even our nation. Our goal is to make sure that women are not prevented by their symptoms from functioning at their highest level. And we have ways of doing that. We can age gracefully. We can accomplish so much after menopause. We should do it.
Yeah, and I was really excited, Trish, to see the numbers because I think some people might not take this seriously unless they see that it impacts the economy. What do workplaces need to do to be inclusive spaces for women who are going through menopause?
Yeah, I think it's really important for workplaces to appreciate that this does hit their bottom line. Women are taking sick days. They're going on short-term disability. They are not taking promotions. They are going from full-time to part-time. They are retiring early. So the data shows that this is what women do in order to cope. They sacrifice their work in order to keep their health and keep other parts of their life going. Employers do not want that to happen. They don't want that as a cost to their bottom line, but they want to keep these women that have all this wisdom and experience and knowledge and can coach and mentor and can move up and break the glass ceiling. So it is a really positive opportunity for employers that they can embrace. And the lift is not that much. It's about educating your workforce. It's about reviewing your policies and looking for anything that can help women at this stage of life, enhancing those policies, looking at their benefits program and do they have coverage for things like pelvic floor therapy or for hormone therapy and other things that would be helpful to a woman in her treatment stage. So not a big lift, really big return.
Christina, Trish mentioned, there is still a stigma around menopause, and you also said that some women might actually ignore their symptoms because actually admitting that something is happening might be just too scary to deal with. I make fun of my husband all the time. I send him memes of what's going on with me. How do men become a part of this conversation? What is their role?
I think we have to really welcome them into this conversation. When I was writing this piece for the Toronto Star, I was out one night with a group of my friends, and we all, as soon as I said what I was talking about, all the women sort of leaned over on the table and we were talking so quickly, hands flying everywhere. And afterwards, one of my friends texted me and said her partner had said to her on the way home, you just pushed us right out of the way, and we see this happening and we are worried about you and we want to be a part of the conversation. So I think in our personal lives, in our workplaces, making sure this is not just a conversation among women, but a conversation for everybody, because it has massive effects on our families, on our workplaces, on the way we all live. And so let's start this conversation about what we can do about it.
Do you feel as if we're reaching a turning point around this conversation?
I think so. I was thinking when Dr. Wolfman came on this call, I remember 15 years ago pitching a story about her work and having zero interest. And in the last year, we've had big stories in the Toronto Star, in the New York Times. We're here today. And so I think the conversation is changing. I do have hope.
I see you nodding, Trish.
I just want to add something. I feel like Canada could become a leader in this. We have an opportunity to take a lead in increasing knowledge to women, in having accessible care and treatment, and in creating menopause inclusive workplaces. We can do this.
And you're saying this because
You're
saying this because the priorities in the U.S. have changed, so maybe this is our opportunity to...
It is our time.
Yeah, and I'd also like to say that my hospital is a leader. We've raised $51 million towards a mature women's health center. And because I'm on the board of the International Menopause Society, I know that no place in the world has that happened. So yes, we
The
have
hot and bothered
Yes.
commercials were amazing.
Yeah, and the Hillary Weston Janice O'Bourne Center, we made an announcement a few days ago about it, and I think we can act as global leaders and have other places emulate what we're doing. So I think the future is rosy. I agree with Christina. I remember in 2018 there is a World Menopause Day in October, and we tried to pitch it to every newspaper, media, and the only one that was interested was Portuguese radio. I think partly that was because cannabis was released at the same time, and they got all the news. And I'm thinking, but half the population is women. Why isn't anybody interested?
We have 1 minute left, so I'm just going to go to Trish. What do you think has changed? Why do you think things are changing right now?
Yeah, I think there's been a confluence of many things. Definitely we have data now in Canada that's been cited around the world, which is amazing. We have more influencers, we have social media, and this is all wonderful because we should be the last generation. Like I feel like the baby boomers should be the last generation that had to deal with the silence, the stigma, the lack of access to treatment and care. Everything should be way better for the generations that are behind us. So let's just make that happen.
There is a lack of education. A lot of people are going online trying to find information. If you don't have a family doctor, you're going to go onto the internet. Do you worry about those gaps because not all the information online is accurate?
I see a menopause gold rush happening right now. I think we're seeing all kinds of companies, whether they're hormones, compounded hormones, different supplements, all kinds of different advice. I think it's a gold rush out there right now for this, and we see it happening before our very eyes. So women need to be careful. It adds to the confusion. It was already complicated. I think this is layering even more complexity to it. But in the end, women must advocate for themselves. They really have to be legitimize their symptoms and the way that they're feeling, and they have a right to feel good. They have a right to be at their peak. They have a right to be at their best. So that is enough for women to fight for.
Don't suffer in silence. Thank you to all of you for being a part of this conversation. I'm really proud that TVO was able to have this on the agenda. Thank you so much for your time. We appreciate it.
Thank you very much.
Thank you.
That is the agenda for Wednesday, March 26, 2025. Tomorrow on the program, how can Canada find new trading partners amidst a tariff war with the U.S.? I'm Nam Kiwanuka. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.